next thing we're going to talk about is quality. So what's going on to make sure that the care you get in a hospital or a clinic is of good quality. There's a lot in the book about this, so I'm just going to add a few things that I think are useful. The first thing that I want to mention is that quality of care is really difficult to measure. So you as a patient didn't go to medical school, you didn't do residency, you don't know what the best diagnostic test for, a sore throat might be, or for someone who comes in with fatigue. You don't necessarily know what the best antibiotic to treat strep throat is. You shouldn't have to, right? But so your ability as a patient to assess the quality of care that you are being given is not awesome, right? Because you don't know, right? If an electrician gave me a plan for this is how I'm going to redo your wiring in your house, I don't know, right? I don't know if it's any good, right? So patient surveys and patient satisfaction surveys, although they're frequently used in healthcare, they are a little bit problematic, right? And so what we see in general, and so these kind of things come up again and again, is the things that patients tend to rate highly is if the doctor is kind and personable, somebody that you really like, if the doctor spends a lot of time with them. If it's a white male, they tend to feel like, oh, that's somebody who really knows what they're doing, right? And if they're neat and good looking, they tend to rate them more highly than people that are not particularly attractive. Also, interestingly, patients rate overweight and obese physicians as far less competent than typical weight physicians, even though the actual care delivered was the same and sometimes even superior. Right, so there's all these things that go into patient satisfaction surveys that are not actually good indicators of quality of care. Patients also really like doctors who will give them antibiotics, even though oftentimes that is not the appropriate medical care for what the patient came in with. But the patient's like, yes, this is going to make me better because they believe that it will, and so yeah, so it's tough sometimes. So what else can we look at? So if patient satisfaction surveys, they help you know about the kind of your customer service aspect of things, and that's an important piece. We want to make sure people feel cared for, but are they actually well cared for is the question. So outcome measures are looking at things like, okay, what percentage of patients in your practice have their blood pressure controlled, right? So of all your people who have high blood pressure, have you gotten their blood pressure levels back to normal by treatment with exercise, diet, and medications, right? What is the death rate in your practice? How well do you make sure that all of the children who come to see you are up to date with their vaccination? So what's your vaccination rate of your people in your practice? So these are all outcomes measures. They're data driven, and so they're objective and relatively easy to measure, especially with an electronic health record. But the problem is that's not entirely within the clinical team's control, right? So whether or not my patients are all fully vaccinated in part has to do with how good of a job am I doing explaining to them the reasons for vaccination and making sure that I check and see, ooh, is somebody falling behind? Ooh, what are they due for? Those are things that I can control. But some people are just fundamentally opposed to vaccination. And if I happen to have a lot of people like that in my practice, that's not necessarily because I'm not doing my job, right? And same thing with blood pressure example. So if I have a cantankerous older lady who's like, I don't want to take my blood pressure medicine, I don't care if I die, I die. But then my colleague has this lovely elder gentleman who says, yes, doctor, whatever you recommend, absolutely, I will do it. Well, they're going to have better numbers than I am. Their data is going to look better than mine. And so you can see that it's really tough. People who work in education talk about this problem as well. If they're judged just based on the test scores, but there are all these other factors that influence how their students do. They're completely outside their control, like are they getting enough to eat? Are they getting enough sleep at night? All those types of things. What's the environment like at home? Then it's problematic. So outcomes measures are useful and they are used in medicine. There are a lot of pay for performance initiatives and other things, but they're tricky. So another way that we assess for quality of care is through peer reviews and institutional reviews, and these take many different forms. So one is periodic chart reviews. I have never worked at a practice or in a setting where we didn't, with some frequency, get assigned chart notes from one of our colleagues, and we had to kind of go through and assess them using a rubric, make sure it seemed like their documentation was sufficient, that the diagnostic conclusion and treatment that they came to was appropriate. So we do that all the time. We find mistakes, we find omissions, and we report that to each other so that we can all improve. So that's a regular occurrence. That's part of standard medical practice that we do peer reviews on a really regular basis. Another common thing that occurs is something called morbidity and mortality reports. So you might remember the word morbidity refers to disability. So if somebody is ill or unwell or loses function, whereas mortality is death. So what these are anytime a bad outcome happens, usually this is in the hospital setting, where something didn't go the way it was supposed to. So somebody had a complication or a bad outcome, then the team that took care of the patient puts together a whole report and goes step by step through the case and everything that happened and identifies all the places when something went wrong. And the goal then is to be able to kind of identify these things so that then we can guard against them in the future. So this is a really well-known practice. It happens in the hospitals pretty much everywhere I've ever been. It's a very humbling experience to have to give one of these, right? Because you're having to confess to all of your colleagues that your team messed up and the patient suffered because of it. But this is a really important piece of accountability and making sure that we ensure quality. Another way we can assure quality of care is through incident reports. So if, for example, a nurse accidentally gives the wrong medication, we fill out an incident report. If a patient slips on the hallway and hits their head, we fill out an incident report. The goal of these is not so much so to then blame the custodian who left the floor a little slippery or the nurse who was too distracted for whatever reason and gave the wrong medication. The goal of incident reports is to identify a potential systems changes that we can make. And so in this unit, we're going to start talking about systemic thinking, which is actually our last unit, but you're going to start to hear about it a little bit. So what are ways that we can help prevent these errors from happening? What are the ways that we can remove the potential for human error? What are the ways we can make it easier to do the right thing and harder to miss something or make a mistake? So there's a lot of things that you can do at the organizational and systems level that can help people perform at their best. So there's a really good video by Atul Gawande, who is a physician who has researched this extensively as part of your immediate assignment. So the last piece is coordination of care. This is a pretty tricky piece in the United States because we have this very fragmented healthcare system. They don't all work for the same people. In fact, they all work for lots of different people, and we have small organizations and large organizations and all kinds of things with no centralized framework at all. Nobody is in charge. Not a one, right? It's all just, I think I'll open a hospital. Okay, fine. And it might drive out the nearby hospital, right? It might drive them out of business, might not. I don't know. It depends, right? It's all haphazard. There's no centralized organization at all. Other industrialized nations, for the most part, have some sort of a national health service or national health system. that in most cases provides a tax-subsidized, no or low-cost point-of-care system. So to go to the doctor, to get a surgery, whatever, usually it costs nothing or very little because it's subsidized by your tax dollars and other people's tax dollars. So that's really interesting from an access standpoint, but it also is really interesting in terms of a centralization and coordination standpoint. So oftentimes that means they're all using the same computerized record system. They are all reporting to the same data collection systems. And this is very different from what we have in the United States, where everybody has a different system. Even different state health departments have different ways of collecting data. So the different categories of ages where they're collecting their COVID numbers, for example, vary from state to state. So then we can't put it all together nationally because it's all different. Okay, but that's public health. We'll get to that later. All right, so some of the three main challenges that we have to coordinating care in the United States for patients are, one is medical records. So most practices now have some form of electronic health record. There are hundreds of different software programs out there for medical records, and every practice kind of has a different one. And even if, for example, so like Mayo Clinic Health System and Prevea both use the same software program, they both use Epic, but they're two different instances of the software, right? So so another example is, when I worked at Student Health Services, we had an electronic health record system, but it was a completely different software system. And so when I referred someone to the surgeon, because they thought they needed their appendix out or their tonsils out or whatever it might be, even though we have all this electronic data, we had to print it out, fax it over to the surgeon's office, and then the surgeon can read it on paper, sign it, and then it gets scanned in as a document into their health record. So we do not have a seamless way to integrate health information from different systems. People are working on this, so there are some organizations now that are saying, okay, you use Epic, we use Epic, let's sign an agreement that says if I'm referring a patient to you, or you're referring a patient to me, we'll figure out a way to be able to synchronize that information and transfer it from one system into the other, or copy it from one system into the other, so that we have that full accessibility of the way to kind of filter and organize the information. So people are working on it, but it's really tough when we have all these different proprietary software systems. The other is insurance coverage. So perhaps you need your tonsils out, and I want to refer you to the surgeon, Dr. Herman's great surgeon here in Menominee, but your insurance won't cover that, right? So maybe your insurance will only cover a physician who's back home for you in La Crosse. Which, if it's a surgery that you can kind of do at your convenience, that's nice. But if it's a surgery that is urgent, then that's difficult, right? And so sometimes we've had patients who were severely ill, even, that we, for lack of better options, bundled into a car for a 4-hour drive to the healthcare organization that their insurance was going to cover. So that's a challenge. That's a real challenge. Finding specialists and organizations that will take your insurance aren't always convenient, and they don't always coordinate with where you got your primary care. And then finally, privacy concerns. So HIPAA, which is the Health Insurance Privacy and Portability Act, says that I cannot, as a healthcare provider, release your protected healthcare information unless you give me direct permission to do so, or it is required for continuation of care. So, for example, if I'm sending you to the emergency room because I think you're septic, I can go ahead and fax records from the visit that you just had with me, and here's what happened, and here's what we did, and here's what the lab test results were, so that the hospital staff will have access to all of that information at their fingertips from a fax, right? I can. But for example, let's say you went to the emergency room on the weekend and they put in some stitches and they said, okay, follow up with your primary care doctor in 5 days to get the stitches out. Well, if you don't tell them who you're going to see because you haven't made the appointment yet and it's the weekend and all that kind of stuff, then usually when you show up to my office 5 days later, I don't have those records. I don't know that they wanted your stitches to come out 5 days later, right? And so then we have to call and say that the patient is here, because a lot of times if we call and you're not there yet, they say, well, we don't know that the patient's actually coming to you and we don't have written permission to give you the records. So sometimes privacy concerns can make things a little bit more difficult for information to flow back and forth. Privacy is super important. We always want to maintain that. No one ever should read a medical record unless they have a medical need to know, unless you're directly caring for that patient and need to know that information. But sometimes it can make it a little bit more difficult to coordinate care. So that's it for healthcare organizations from my standpoint. There's some additional material in the book and some really good videos. I hope you feel the same way for your immediate assignments. So talking about all the different types of healthcare organizations that we have, a little bit about how they get paid, which is important for understanding access from a financial standpoint, but then we also talked about from kind of a geographic and transportation standpoint, what are some of the measures in place to help ensure quality care, and then some of the challenges that we have with coordinating care between all of these different healthcare organizations. All right. Thanks so much.